Okay, so hello everyone, and I'd like to start this Tobacco Endgame Centre Research Excellence webinar by acknowledging the Jagera and Turrbal peoples who are the traditional owners of the lands that I am on. I pay my respect to their ancestors and descendants who continue cultural and spiritual connection to country, and extend my respect to all First Nations peoples who are joining us for this online event. Today's webinar is focused on a population that continues to experience tobacco-related disease at a much higher rate than the overall population in Australia. People living with a mental illness are more likely to take up smoking and experience more difficulty in stopping. And so I'm really looking forward to hearing about this research that addresses this priority population for smoking cessation interventions. Our speaker today is Dr. Kristen McCarter, who is a clinical psychologist and lecturer in the School of Psychological Sciences at the University of Newcastle. Kristen's research is focused on increasing survival rates among people living with cancer and interventions to assist people to quit smoking. She was a trial coordinator for Quitline, which was a multi-site randomised controlled trial that evaluated the effectiveness of a tailored Quitline intervention for people experiencing severe mental illness. And if you have questions for Kristen as she's talking, just put them in the Q&A tab on the webinar function, and I'll come to these at the end of the talk, and we'll have some Q&A time. And now it's my great pleasure to hand over to Dr. McCarter to tell us more about this important research and hear about these findings. Thank you.
Thanks, Carol. Thanks everyone for having me today to talk about this research. So as Carol mentioned, my name's Kristen. I'm a clinical psychologist and a lecturer in the School of Psychology at University of Newcastle, and I was the trial coordinator for this project that I'm going to talk to you about. So the project was called Quitline. It was a randomized control trial of a peer worker facilitated Quitline support intervention for people, largely with people with severe mental illness. So as was just sort of mentioned, we know that people who experience severe mental illness smoke at much higher rates than the general population, and we have this big mortality gap of people dying on average 10 to 20 years earlier, largely from cardiovascular diseases and smoking-related diseases. So we know that smoking for many of the population groups that we work with is one of the major modifiable risk factors for premature mortality in this population. We have evidence to suggest that people who experience severe mental illness are just as motivated to quit smoking as the general population. However, they do have overall lower levels of success with cessation. And that's due to a number of factors, but also including not routinely receiving tobacco treatment support. So we know that telephone delivery, like Quitlines of tobacco treatment counselling, have the potential to improve access and can be beneficial for people who experience severe mental illness. But we also know that Quitlines are underutilised, and we need more effort to engage people in accepting Quitline support and engaging with that treatment. We also know that mental health peer workers bring their lived experience of mental ill health and recovery to engage and support people in mental health services, and there's a potential there for them to be able to engage people and use their expertise to support people with tobacco treatment. And then I've just listed there some of the unique barriers that I mentioned to tobacco use recovery. So despite knowing that people with severe mental illness are as motivated to quit, they're less successful overall, and that's due to a number of these barriers that we see. And that can include things like financial stress, and when we're thinking about stigma, important to also think about things like internalized stigma, the greater likelihood of living with other smokers, and higher levels of nicotine dependence, and the potential for more severe withdrawal symptoms when quitting smoking. So that's some of the unique barriers in this population to quitting smoking. So in this Quitline trial, it was a NHMRC funded trial. The CIA was Professor Amanda Baker. As I mentioned, I was the trial coordinator, and then we had collaborations between a few different universities as well as some partner organisations. Quitline as well. So as I mentioned, Quitline is one of those services that already exists and has the potential to help people, but it's extremely underutilised. And we also know that we have these evidence-based treatments, things like Quitlines, things like nicotine replacement therapy, but they aren't accessed or provided well enough. And in part, that's sometimes because health professionals lack the awareness and expertise in helping people with severe mental illness who are also smokers. So as part of this study, the idea was really to link people with these existing services, Quitline and nicotine replacement therapy. And peer workers were used to recruit and engage people with the study, as well as the proactive referrals to Quitline, and some other things as well. I'll talk through the peer worker role kind of as we go through. But essentially, all participants were provided with advice to quit, a provision of quit pack written materials, and information on nicotine replacement therapy. And that sort of acted as our standard care or active control condition. And then there was an intervention condition as well, and I'll step you through what people received in that role. But that's sort of just a brief sort of overview of the study. And then as part of the study, we followed people up at 2 months, 5 months, and 8 months post baseline being our primary outcome measure. So as I mentioned, we had a standard smoking care group. You could call it an active control group, given that this is what we would anticipate or what should be provided to people who are accessing mental health services, although we know that is not always the case, or that's not always routinely provided. So this is what was provided to participants randomized to the control condition. And then for those people that were randomized to the intervention condition, they received all of those things, plus a proactive referral to tailored Quitline counselling. So the Quitline counselling in this condition that was provided by Quit Victoria was tailored in the sense that people received a proactive referral, as I mentioned, so Quitline contacted participants rather than the other way around. They also had a dedicated Quitline counsellor. So standard Quitline practice is that people won't receive necessarily the same counsellor each time they call up. As part of the study, as part of the QuitLink study and the intervention condition, participants had a dedicated counsellor. So they spoke to the same counsellor each time. And then we also offered people up to 8 weeks of free combination NRT, so patches, and then their choice of an oral form of NRT. So as I mentioned, peer workers were also a big part of the study. So we had peer workers with experience of mental ill health and recovery, and some with experience of stopping smoking. And they were embedded within the services that we recruited participants from. They conducted our baseline assessments as part of the study. They provided that brief intervention that was given to all participants as part of standard care. So the brief advice to quit and encouragement to call Quitline. And then they also facilitated the referral of intervention participants to Quitline. So as part of our initial recruitment method that was really focused on the peer workers that were embedded within the organisations we were recruiting from, which was Mind Australia and St Vincent's Mental Health Services in Victoria. So we had peer workers embedded within those organisations, giving face-to-face presentations within Mind Australia. That was largely in residential services, and Mind inpatient and outpatient services. So peer workers did face-to-face presentations where they could to anyone that was sort of about the study, and then they were able to provide more information and recruit people. So that was one of our first recruitment strategies. As you can see, we recruited 29 people over 13 months. So based on COVID, as well as lower than anticipated recruitment. So obviously with COVID, services were shut down and we weren't able to do those face-to-face recruitments. Throughout the study, we added an additional recruitment method, which was via direct mail postcards. So for Mind Australia and for St Vincent's, we sent out in 2 batches. So we did 1 lot and then we did a second prompt lot of postcards advertising the study directly to clients and consumers of those services. So we didn't know who were smokers and who were not. We just had access to clients and consumers of those services within the past year, and postcards about the study were sent out direct to their addresses. And so through that recruitment strategy, as you can see, we recruited 67 people over the 6 months. And then we also decided to add paid Facebook advertisements sort of towards the end of the study. Again, largely due to the adaptations we had to make due to COVID kind of interrupting things, and then also overall generally lower than anticipated recruitment. So we added paid Facebook advertising as well. And we recruited 14 people over the 4 months that we did that. So at the time that we expanded to the paid Facebook ads, we also expanded our eligibility criteria. So being able to do the advertisements online meant that we could expand things a little bit. So we also decided to expand our recruitment criteria to anyone who was accessing support for a mental health or drug and alcohol condition. So that could have included a GP or a psychologist, any kind of support. So in the first 2 recruitment strategies, we largely recruited people with a severe mental illness just because of the consumer and client population that those services tend to provide support to. And then as part of the paid Facebook advertisement, things were expanded more to people, anyone that was accessing support for a mental health or drug and alcohol condition. So in total, we recruited 109 participants. And in terms of the results, just some demographics of the people that we recruited, about half the sample was female, and our average age was around 45 years, and most people were receiving a disability support benefit. And as I mentioned, largely the study sample still reflected overall people who are experiencing a severe mental ill health. So most of the people in our sample had a diagnosis of a psychotic disorder. In terms of some other clinical characteristics that we measured, about half the sample consumed alcohol excessively according to national guidelines, and a quarter had used cannabis in the previous month. The sample mean health-related quality of life, this is a utility score. So this is measured from the EQ5D, and that score is anchored by 1 equals perfect and 0 equals death. So our mean health-related quality of life score at baseline was 0.5, so indicating relatively poor health-related quality of life for our sample. In terms of tobacco dependence, we had moderate to high tobacco dependence on average on the heaviness of smoking index, with people smoking around 20 cigarettes per day at baseline. Almost half of the sample had made a quit attempt at some time, with about half trying to quit in the past year. So we can see there that although motivation to quit was high, and the majority of people were trying to cut down, confidence in quitting was low, which is sort of reflective of what I spoke about just previously in terms of what we know about this population, that they're as motivated to quit, but potentially confidence and encouragement to access support and tailoring support is where we need to focus our attention. So in terms of those people that were allocated to the intervention condition and received that tailored Quitline support with a dedicated counsellor, most of the 54 participants that were allocated to that intervention condition, 51 agreed to the proactive referral to Quitline, and 48 of them received any number of Quitline calls. So the majority were able to be contacted and engaged in Quitline. 6 of the participants that were allocated to the control condition contacted the Quitline sort of their own volition and received standard Quitline counselling as part of that brief advice to quit and to contact Quitline for those people that were in the control condition. But I've just presented here for the intervention group just to sort of give an overall indication of satisfaction with the Quitline counselling that they received. The majority found the Quitline counsellor provided information and strategies that were relevant and were very much satisfied with the service, and would call the Quitline in future if they wanted help with quitting, and recommended Quitline to others. So in terms of our primary outcomes for the study, we had hypothesized that we would see an abstinence rate at 6 months continuous abstinence of 1% in the control arm and 8% in the intervention arm at 8-month follow-up. So the 6 and 8 month there, it's an 8-month follow-up, but we gave people a 2-month period, which was essentially the intervention period for those that were randomized to the intervention group, where they had the Quitline counselling and the 8 weeks of nicotine replacement therapy. So we'd hypothesized we'd see that difference of 1% and 8%. That's essentially what we found. You can see the 2% and 16% there. So we saw a large difference in the 6 months continuous abstinence rate of smoking, which was our primary outcome, which was quite promising, although this was not statistically significant. And so, we do think that is probably due to our study being underpowered. And so that's a promising trend in line with some of the other outcomes that I'll present here as well, that kind of gives us an indication that there was a real benefit for people in the Quitline condition. So at the 2-month follow-up, so just at the end of that intervention period for those people that were in randomized to the intervention group, there was a significant difference in the odds of 7-day point prevalence abstinence between the Quitline and control conditions, and that effect was statistically significant. And then this is just to show you over the 2, 5, and 8 months for that 7-day point prevalence abstinence as a secondary outcome, we found the statistically significant difference at the 2-month, and then that effect dropped off over time for that secondary outcome. In terms of just looking at other secondary outcomes at 2-month follow-up, the number of cigarettes smoked per day was significantly different between the groups as well, in favour of the Quitline condition. So that's sort of some of the quantitative outcomes and our primary outcome, which we are currently writing up at the moment. So these findings are hot off the press. But I also just wanted to take the time to talk through some of the qualitative findings that we found as well as part of the study. So we had a qualitative study embedded within the overall RCT. And I think that just provides a little bit of nuance to the findings and supports some of the findings as well. So we conducted interviews with 29 participants at that 2-month time point. So that first follow-up time point, immediately following the intervention period for those people that were randomized to the intervention condition. We did the interviews across, as you can see, a good representation of intervention and control participants. And we used a semi-structured interview guide, asking people about different components of the intervention, the research, but also their experiences of getting help to address smoking, both within the study and their history of getting help to quit smoking. And also the support that they'd received from other services and other health professionals historically, as well as during the study. So we audio recorded those interviews and we used an inductive thematic analysis. And so I just wanted to talk through, I guess, some of the themes there and the implications that they might have. So in terms of what we found across the interviews, this was generally spread across these 4 overall themes, with some sub-themes throughout. So this is one of the themes that we found, and essentially this long and complex journey theme was really around an understanding of how smoking is contextualized within participants' lives. And this was quite important, particularly for the population of people that we had recruited. So in terms of particularly people who are experiencing severe mental illness, we found that there was really this long and complex journey with smoking and tobacco use recovery, and the really deeply intertwined nature of smoking and the challenges that people were experiencing with quitting, and how that's sort of intertwined with people's somewhat chaotic and disrupted lives. And this really reflected a sense of powerlessness and a lack of choice for people, even in terms of things like, the poverty that was a common feature of people's lives. And as we know, sometimes for people who smoking cigarettes meant that they couldn't afford other necessities. But it also highlighted, as I mentioned earlier, what we know from the literature and some of the quantitative findings that we had from participants at baseline, that people were really determined to quit and had a desire to quit, despite all of these different challenges that they outlined in these chaotic lives. And so in the context of these difficult circumstances, people had made multiple quit attempts prior to joining the study. As I mentioned at the start, there's many unique barriers that affect this population for quitting smoking. And unsurprisingly, there were many barriers and factors that people spoke about in terms of what they thought impacted either positively or negatively on quitting smoking. People spoke about the importance of having a desire to quit and demonstrating self-control to engage in tobacco treatment, which is reflective of other populations of people that smoke. Essentially, the different barriers and facilitators that people spoke about in these interviews really encompassed what we would probably call across the personal, so things like stress, mental health, boredom, and then the social domains, so things like family, friends, living situation, environment, financial resources, and COVID as well, was something that people spoke about. In terms of the study specifically, people or participants in these interviews at least expressed gratitude for an invitation and the opportunity to participate in the Quitline study, which I found really interesting, particularly in a study where we're linking people to existing, evidence-based supports. People spoke about feeling, lucky to have had their, name pulled out of a hat, essentially, and be invited to participate in the study through something like a direct mail postcard. And so it really appeared that they'd had really minimal opportunities in the past to be involved in an offer of support that was also tailored, to the difficulties that they were experiencing. In terms of the involvement of the peer researchers, that was a bit of a mixed response. So some people didn't recall or necessarily distinguish the involvement of the peer researchers who did the recruitment and the baseline assessment from the research assistants who subsequently collected data via the telephone at follow-up for people. But for those people who did distinguish that and valued the role of the peer researcher, the important thing that came out there was this unique shared understanding and knowing that someone had that experience of mental health and recovery, and that was reflected in what people spoke about. People spoke about the importance of a range of different components of the study, but mainly reflecting an appreciation of relevant and experienced support. So for Quitline in particular, knowing that the Quitline counsellors were trained in supporting people to quit smoking, people who are experiencing mental ill health, and that experience that they had around that, the deliberate use of counsellors, Quitline counsellors who'd had that training, was particularly appreciated. And then beyond, the kind of practical elements of information and skills building and coping strategies that Quitline counsellors provided, participants spoke about this appreciation for the counsellors really meeting people where they were at and continued encouragement, and people emphasised, a gratitude for that collaborative model of working that perhaps they weren't aware of in Quitline before. And then there was really this overarching theme of compassion, which was something that was sort of a surprising finding that came out in the sense that it wasn't something that was particularly, targeted or necessarily something that we asked about or put into the intervention, but because of the way that the peer workers, approached people and engaged them in the study, the experience of the Quitline counsellors in being non-judgmental and meeting people where they were at, and being able to take lessons learned perhaps from goals that weren't met for quitting on a certain date, or being able to achieve what people wanted. There was this overarching theme of compassion that came out, and so we found mixed evidence of support that people had from their current health professionals, so in terms of psychiatrists, GPs, psychologists, and support workers. And so that support really varied in quality for people, and the impact that it had on them. But what was evident in those people who had support and those people who didn't have support was that encouragement and compassion were key things that they appreciated. And so that non-judgmental stance, like I mentioned, was something that was specifically appreciated, and it was something that was specific to intervention participants. So it really came up as something that was appreciated from the Quitline counsellors, as people feeling safe in the knowledge that the counsellors wouldn't judge them for smoking relapse, and as I mentioned, would help them find learnings from that. And so that was something that sort of people carried through from the start of the study, even through to the follow-up telephone surveys conducted by research assistants, was this compassionate approach that people really found important and thought was something that was important for tobacco treatment for this population. So that's sort of, a quick run through, I suppose, of the overall primary quantitative findings, and then hopefully the qualitative findings, providing a little bit of nuance to what we found. But essentially, to kind of wrap everything up, what does this all mean? We did find a sizable difference in our long-term quit rates of the continuous abstinence at 8 months. And it was in the direction we predicted. So although that wasn't significant, as I mentioned, we do believe that was due to the study being underpowered. And so to put that in context, we've got our rate of 16% continuous abstinence from smoking at that 8-month follow-up after baseline. And that really compares favourably with the only other study, RCT, that we're aware of that's being conducted using a Quitline service among a sample of people living with psychotic disorders, in which they found a prolonged abstinence rate of 7%. And then, as I mentioned, our point prevalence abstinence, 7 days point prevalence abstinence, and average number of cigarettes smoked per day favoured the Quitline condition as well, compared to the control condition, and that was significantly so at 2 months. So these sort of quantitative findings overall are consistent with the notion that Quitline has provided a real benefit to those people in the intervention condition. In terms of what we found overall from the quantitative and qualitative findings, as I mentioned, there is a strong desire to quit smoking in this population, and people are working really hard to quit. So despite the numerous barriers that they're facing, many participants did speak about making quit attempts. And so, any kind of myths or notions around this population, not being motivated to quit or not wanting to quit, were really kind of added to the evidence to dispel that. Although our participants were all engaged with mental health services, and many of them also mentioned other primary care providers, it appears that most of them hadn't previously engaged with tobacco treatment, or what had been offered to them might not have been person-centered or ineffectual. And this is despite these indicators that they were willing to engage with quitting. And so encouragement to accept support for things like proactive Quitline referrals is helpful. And for our participants, when they were linked with Quitline, by far most people engaged with Quitline and found the support was something that they highly valued. And so letting people know that Quitline has this expertise to support people with mental ill health to quit smoking, and that's relevant and experienced counsellors that are there to support them. But also besides that practical support that Quitline offers, the other things that people valued in terms of the non-judgmental, compassionate stance is something that, we can pass on to people as well. For services, in terms of our recruitment strategies, our direct mail postcards were by far the most effective in terms of recruiting people and therefore linking them to a service like Quitline. And as I mentioned, we sent out those postcards twice. And so people that were not ready at one time point were then ready at another time point and engaged with the study. And that was something that people spoke about in the qualitative interviews as well. Having that second prompt was sometimes what they needed to kind of ring up and engage with the study. So, this is a really low cost sort of thing that services might be able to roll out in terms of prompting people to engage in tobacco treatment. We have good evidence now that quitting smoking does not worsen mental health, but, to add to that, our psychological distress scores did not worsen in either condition, and our rates of psychiatric adverse events did not differ between conditions across the trial. So that just adds further support to those findings. In terms of our exclusion criteria for the study, that was quite minimal. And so these findings are likely to be representative of people that are receiving mental health services in the community. And obviously, we're looking to future studies to further examine the effectiveness of Quitline interventions among larger samples of people experiencing mental ill health. But in the absence of that, as I mentioned, I think our findings are consistent with what we could consider a real benefit for people, and we can feel confident in I think now having a conversation about how we might use some of these implications for services and research. So that's all from me. I'll stop sharing.
Thanks, Kristen. Yes, so if you want to take it off share screen, that's great. Okay, so we do have some questions. So Stu's asked, first he said, great presentation to you. So yeah, I agree with that. It was fantastic. He's asked, what training did the mental health peer workers receive?
So the peer workers that we employed or embedded as part of the study were already working as peer workers in these services. And so they had previous training and experience in doing that role. But we did also provide them training sort of more in the research components of the study, in the sense of, completing assessments and referrals to Quitline. But they were experienced peer workers. And so in our paper, we've even referred to them as peer researchers in the sense that they had a bit of a dual role. So I think it would be important going forward, if we had peer workers that weren't necessarily embedded within the organizations that you were partnering with, that would be something to consider, rather than, having them go in sort of cold as peer workers necessarily associated with a study and going into a service. So I think having that legitimacy in terms of having them embedded as well. And certainly I think, we were lucky to have peer workers that were experienced in sort of delivering that experience and expertise as part of the study. We did also do a weekly supervision with the peers across the active phase of the trial while we were recruiting people as well, just to talk through largely research sort of issues as well, but there were clinical things that came up too. So supporting them as well, I think, in addition to any kind of initial training, is something that would be important.
So those peer workers, were they already providing a brief intervention for smoking cessation before the study, or was that something that was introduced to them and continued on afterwards?
So the peer workers had their experience was largely in the mental ill health and recovery component, working in the mental health services. Anecdotally, I don't think that they had necessarily been providing any smoking specific care within those services. But I think, again, the peers that we had, we were lucky that they had, but also we recruited peers that had that experience with smoking and stopping smoking as well. So they had that that sort of experience to fall back on.
And you had an excellent quit rate of 16%. That's really fantastic. Was that a self-reported quit rate, or did you also manage to get some bioconfirmation from
Yeah,
them?
so originally the primary outcome was going to be biochemically verified abstinence. And then when COVID kind of threw a spanner in the works for everything, we had to change to self-reported, yeah.
And did you measure adherence to the counselling and also the nicotine replacement therapy? What sort of rates did you get in the intervention and the control arms for just adherence to those interventions?
Adherence from the counsellors or from the participants?
Oh, well, from either, I guess, who reported where you collected the information from, whether it was from the participant or from the counsellor delivering?
Yeah, so we have extracted data from Quitline. So we have information on the number of calls people received. I think the range was from 2 to 11, with an average, I think, of 6 calls that people received in the intervention condition. And then in terms of we did measure people's use of NRT, although we asked, had they used NRT in the previous week and how much had they used. So certainly subject to people's kind of recall bias in that sense. But in terms of people, we offered the NRT up to 8 weeks of NRT in 2 batches, and all intervention participants requested to receive the second batch. They were wanting to receive that. And then in terms of all of the Quitline counselling and fidelity to the manual that they'd been trained in for this particular project, there's actually a PhD student at the moment working on that with Quitline, looking at fidelity and BCTs and other things around the Quitline counselling as well.
Mm. And for the NRT intervention, did you give people combination therapy or was it patches alone?
Yes, yeah. So we gave people combination therapy, and we gave them the option to choose what they would like. So everyone received patches, and then they were able to choose up to 2 different kinds of oral NRT for each batch. So we had gum, lozenges, mist, and what's the other?
Inhalator?
Inhalator, yes. Yes. So we had all of those options and people were able to self-select what they would like. So in the second batch as well, people were able to try something different.
And when you conducted the qualitative interviews, did you ask people about, whether they had hesitation about engaging with Quitline before the study and how that may have changed? Or was everyone quite happy to call Quitline or have a call from Quitline?
Yeah, no, I think that's a really important thing that came out from the interviews in terms of people being, speaking about the idea that they would never have rang up to, say, hey, I want to quit smoking, or hey, I want to get support to quit smoking in terms of the study, but also Quitline without this study. And I think through some of those findings, like I mentioned, in terms of the meeting people where they were at and the collaborative model and the experience that the Quitline counsellors had, particularly in terms of working with people with mental ill health, the non-judgmental stance that they had, in addition to all of the kind of practical things that people spoke about a lot as well, in terms of different coping strategies and how to use NRT and all those kinds of things. I think that's for me, that's a really big takeaway from the study in terms of how we can better sell Quitline to people and let them know that the Quitline counsellors are quite experienced, that there is, particular components of Quitline that are, specific to working with people with mental health. So I didn't have time in the presentation, but as part of the counselling that Quitline offers for people with mental ill health, they have a focus on strategies that dually benefit mood and quitting smoking, and monitor people's withdrawal symptoms, so they can help people distinguish between short-term withdrawal symptoms and mental health symptoms to kind of tease out some of that for people. And so, yeah, I think making people aware of all of those benefits of Quitline is something that we can do a better job of.
Mm-hmm. So was some of the hesitation around engaging with Quitline before around feeling that stigma and maybe expecting like a negative experience from a Quitline counsellor?
Yeah, I think although people didn't explicitly talk in a lot of detail about specifics in terms of the negative attitudes they had, I think what came out in their the things that they appreciated in terms of, and I've just published the qualitative paper, but there are quotes in there around, this counselor was an angel, and I cried with her, and all these kinds of things. I think the things that people spoke about give an indication of perhaps what they were not aware of and were not expecting.
Mm.
And I think there was only probably maybe one comment throughout the interviews around someone, not wanting to engage due to the idea of potentially Quitline counsellors being people who hadn't smoked before. So that was sort of probably one of the only real overt kind of things that someone spoke about in terms of an attitude towards Quitline. But I think it was potentially not necessarily specifically negatives that people had, but more of just a lack of, and just an empty kind of space around like what Quitline is that was able to be filled in.
Yeah. And it sounds like there's some good recommendations there for using things like postcards to clients to encourage them to engage with Quitline. Has that been rolled out now?
It's not been rolled out, but it's something that I'm looking to test further if I can in future research. So obviously we had partnered with a couple of organisations, and as I mentioned, had largely kind of anticipated to recruit through face-to-face and peer worker kind of engagement. And with the geographical spread of some of the services and COVID, we had to kind of pivot to that postcard approach. That was something we weren't anticipating to do. But given it was, certainly our most successful, and through our qualitative findings, almost a personalized invitation that people really appreciated. I think that's also, definitely one of the key findings from the study that yes, services now could be looking to roll out, but it's something that I'd like to test further as well by trialing that approach with a greater number of organizations to see, and also using some of those, some of the messages and lessons that we've learned in this study, being able to use those on the postcards and kind of provide people more information to engage them.
That's excellent. Okay, so do we have any other comments or questions from the audience? So I've got one here. Did any participants have negative I think we've already answered that basically. Yep. And were there any other concerns that people experienced or shared with the staff about previous experiences with quitting? Like particularly maybe with some previous experiences with accessing Quitline or not wanting to access it?
Yeah, not in terms of Quitline specifically, but I think overall, what we saw was, as I mentioned, sort of people's experiences on the whole with services in general or other allied health professionals, a pretty mixed bag of support, but overall kind of, I guess, reflective of, unfortunately, what we know, that people, aren't being offered this support for a multitude of different reasons. And I think that's probably another key finding for services and clinicians as well, that, we can't assume that someone has had this conversation with their GP or with someone else, and you might be the first person that is having this conversation. And as we found in the study, not just making people aware of the support, but encouragement to accept the support and tell people a little bit more about what is offered when they take it up, is somewhere we can go to kind of bridge that gap.
Excellent. Okay, so I think I'll wrap it up there, give people time to get to their next meeting. So thank you so much, Kristen. That was an excellent presentation. And thank you everyone who's joined today, and I'm sure that you found it enjoyable and an interesting study to find out about. Thanks a
No
lot.
worries. Thank you.
Bye.